So now we're going to talk about assessment and treatment of shock. And we're going to look for hemorrhage. We're going to look for the signs of shock with the altered level of consciousness, the skin changes in terms of color, temperature, and moisture. Look for cool, pale, clammy skin. We're going to look for tachycardia, the elevated heart rate, as well as the loss of peripheral pulses. Look for tachypnea, the elevated respiratory rate. And eventually we're going to look for hypotension when actual measured blood pressure is lower than we would expect. And we're going to be careful to not only think of hemorrhage as external that we can see, and to be especially cautious for internal hemorrhage, especially in the abdominal cavity. Now watch that level of consciousness, realizing that as perfusion decreases to the brain, then the brain doesn't function as well, and we have an altered mental status. We're going to try to differentiate between the altered mental status caused from hypoxia and shock and that from other causes. And to be safe, we should always assume that our patient with altered mental status in a trauma situation has altered mental status due to hypoxia or shock. They may well have alcohol or drugs involved. There may be a glucose issue. There may be a pre-existing altered mental status to some extent. But we need to always be sure that we watch for hypoxia and shock, because that'll kill them, and the others we can correct. Again, skin changes will happen as part of the compensatory mechanism as the body vasoconstricts in order to shunt blood away from the periphery and toward the heart, lung, and brain. Then the skin will get pale because there's not as much red blood going by. The skin will get cool because there's not as much warm blood going by. And then we'll have a clammy or sweaty feeling as part of this decreased blood flow to the skin. And then cap refill, which we know is not particularly accurate as a measure of systemic perfusion. We can't really assess how well the body is perfused with cap refill, especially in adults, but we can assess the perfusion to the extremity, to the area where you're checking cap refill. And then on pulse, we're looking for an elevated heart rate. Remember, you can lose a third of your blood volume before you show any real marked tachycardia, anything over 120. But the quality of that pulse, if that peripheral pulse is weak and thready, that gives you an idea that there's not much circulation down there. And so location on this slide is referring to the use of peripheral pulses as an estimation for blood pressure and as an assessment of hypoperfusion. As far as respiration goes, the whole key here is to prevent hypoxia, to continue to deliver oxygen to the cells so that aerobic metabolism can occur, so that acidosis does not become a problem. But as hypoxia and acidosis start to occur, then the respiratory system is stimulated, since we do breathe off of our CO2 levels. And the respiratory center is stimulated, and that increases that respiratory rate, and that can be a very early sign of shock. Again, it can also be confused with, just like altered mental status, the person who's upset and emotional breathing rapid. Now, is that tachypnea from fear and emotional disturbance, or is it from shock? And we're going to need to always assume that it is the worst, and if it is less than that, then our patients are covered. Remember, blood pressure is not going to drop until you've lost a third of your blood volume. It is a late sign. Hypotension and shock are not the same thing, not even close. And so blood pressure is not even part of your primary assessment. Now, peripheral perfusion is part of your primary assessment, and we ask our students to have a hand on a radial pulse within the first 30 seconds at least of contacting a trauma patient, because that gets you a lot of information. It allows you to estimate a blood pressure. But actually measuring the blood pressure is not part of that primary assessment. It comes in at the start of the secondary assessment. And if you remember, in some cases, patient will be so critical that you'll never even get a secondary assessment done, which means you will take a critical trauma patient into the trauma center and you won't have measured a blood pressure, and that's just fine. And I'll go back for a second. Our treatment is not aimed at trying to return that blood pressure to normal. Our treatments will be aimed at returning perfusion to normal. So we're going to try to get a radial pulse back. We're not going to try to get a blood pressure back to the 120/70 or whatever they had beforehand. Then there's other things that makes this more difficult. Medicine's many shades of gray, and it's hard to have black and white distinctions here. As your patients get older, they have more and more comorbidities. They have more and more things that that are going on with them. They're taking medications. Certainly pregnant patients are very complicated. They can compensate even longer, and they're somewhat, their vitals are somewhat skewed toward looking like they're in shock to start with before they ever have any problems, just as a matter of normal changes in pregnancy. And then, the patient with a seizure disorder, the patient with high blood pressure, the patient with diabetes, those folks have trauma also. And maybe it's one of those things that caused the trauma. So we tend to think in terms of it's either a medical case or a trauma case, but that's just not real world. In the multiple shades of gray that we deal with, you can have medical issues that cause trauma or vice versa. At any rate, you need to assume that your trauma patient, especially if they show any signs of shock, they're bleeding somewhere, even if you can't find it yet. And look closely externally, but remember that there's many internal sources for significant blood loss in the chest and abdomen. On the chest, you usually have some external signs and some clues, but the belly's not that way. And abdominal trauma is a big deal, and it's a hidden source of hypovolemia. As far as fractures go, there's a few that can cause us big problems. One or two femurs can cause significant blood loss. Pelvic fractures can cause massive blood loss. There's a picture at the bottom of that slide of the three most common types of pelvic fractures. All of them can cause significant blood loss. And then when you just add up the rather insignificant blood loss from a number of fractures, then you can get into a problem where hypovolemia has become a deal just based on the number of fractures. And so we can do some stuff with that. We can deal with those long bones. We can deal with the pelvic fracture to some extent with proper splinting and hopefully reduce some of that blood loss. And anytime they talk trauma classes talk about penetrating, they talk about blunt, and draw some distinctions between there. I won't spend very much time on that. It's good reading in the book, but nothing to take up too much of your time with, except to make the point that blunt injuries are a little bit trickier to figure out what all went on. If you see a gunshot and you see an entrance wound and an exit wound, or at least two wounds, you can pretty well guess that the pathway went between those two wounds, and you can guess that internally that pathway is devastating compared to what you can see externally. But with blunt injuries, it's harder to get a feel for all those forces that went on. Were those internal organs, whether they were hollow or solid, were they sheared off or torn, and what blood vessels got moved around? And just try to remember that, especially with motor vehicle crashes, as your patient hurtles down the highway at 70 miles an hour, all their internal organs are going at 70 miles an hour. So just because the car came to a rapid stop doesn't mean that the aorta and the liver came to exactly the same as a rapid stop. Speaking of aortas, and I was kind of raised my eyebrows at that stat at the bottom that 80 to 85% of people with an aortic rupture die pre-hospital. I'm surprised it's not 98% of those folks. But again, the deal is that your aorta is somewhat mobile, and we'll show you the cadaver lab autopsy videos, and you get a chance to see, at least from that perspective, there is quite a bit of movement in there, but at some point you can get a tear, and your aorta is really not rated for 70 miles an hour. So when those sorts of organs have to undergo those forces, they don't do so well. Hemothorax, blood in the chest cavity, outside the lung, inside the chest cavity, into the pleural space that should have nothing in it but a small amount of fluid, can fill up with blood. Matter of fact, you can dump your entire blood volume into your chest. Each half of your chest, they say, can hold 3 to 4 liters of blood, and I would say at least 3 to 4 liters of blood. And so you can completely exsanguinate. You can bleed out internally into your chest cavity and never have any external bleeding. Mentioned a little bit ahead of myself a couple minutes ago about hollow organs as well as the solid organs. And one of the additional problems with abdominal injuries is that the contents of those organs then leaks out. So now you have bile, you have gastric enzymes, you have what should be inside the bowel out loose in the abdomen. And so then you have the additional issues of infectious risk from that, in addition to just simply the bleeding. and peritonitis, which is essentially what I just said. So again, fractures, femur or pelvics are the ones that we worry about the most. And here's a pretty good slide showing you some potential, not average, but potential blood losses. And the humerus, I thought, stood out there. I would have thought the humerus would have been less than that, would have been in the 250 to 500 range. And so I think, most of the time when we see humeral fractures, those tend to be some of the elderly patients who are falling. And so let's don't underestimate the potential blood loss there. That's, half as much as a femur. One femur, a liter or so, up to 2 liters, both femurs can be, 30% of your blood volume right there, and the pelvis can be most of it. In the breathing presentation, we talked about rib fractures, and it's not just if they damage a lung, whether it's from bruising or from an actual puncture in the pneumothorax, but it's also that livers and spleens can be lacerated, as well as the pain from those rib fractures will cause you to hypoventilate, to not breathe as deeply as you should. Neurogenic shock is kind of the hard one for folks to get a feel with. I mean, you can understand if the pump's not working in cardiogenic shock, you can understand if you lost volume in hypovolemic shock, but the container shock or distributive shock, and neurogenic is the one that we talk about with trauma. Those are the ones a little bit harder to conceptualize, and we talked about the loss of sympathetic vascular tone, which means in English that when blood vessels aren't told to stay somewhat constricted and have some vascular tone, they just relax. And they are told to do that by the message being sent down the spinal cord. And so when there is a fracture in the upper regions, in the C-spine or upper T-spine, then you can lose that sympathetic vascular tone because the messages are not getting through and the blood vessels will dilate. Which then, as they dilate, that reduces preload. As preload reduces, cardiac output reduces. As cardiac output reduces, the only way to keep blood pressure up is to increase systemic vascular resistance, but that mechanism's broken. That's what started this whole problem. And so hypotension ensues, hypoperfusion first, and then hypotension after that. And these folks are a little bit harder to assess because they don't have the typical compensatory signs that you pick up. Many times they won't have the tachycardia, they won't have the cool pale clammy skin because the messages from the compensation mechanism are not getting through. On cardiogenic shock, they're talking pneumothorax as part of that. We tend to talk about it also as an obstructive shock, but if it's obstructing anything, it would be obstructing the function of the pump. Particularly, it's usually compressing the heart and also compressing the vena cava as it returns blood. So preload is reduced. And this, again, is a respiratory issue, but it's more of a cardiovascular issue than a respiratory issue, even though it involves a collapsed lung. In a simple pneumothorax, is not producing any pressure on the vena cava or on the structures in the mediastinum. It becomes a tension when it does exert some pressure there. And we're looking at signs of a tension as decreased lung sounds and decreased peripheral pulses. And remember, we're not sitting and waiting for the very late and difficult to pick up sign of tracheal deviation. Once we have decreased lung sounds and decreased peripheral pulses, we're going to rule out that tension and try to fix that. Other problems that can cause cardiogenic shock would be a direct blunt injury to the myocardium, either causing dysrhythmias or causing the heart muscle to not work as well. And then pericardial tamponade. And again, here a small amount of blood in that pericardial sac. It's a thin sac, but it's very tough, and it will only stretch a little bit. And so as blood tends to leak out in there, it compresses the ventricles. The ventricles can't fill, even if there is adequate preload. They can't fill it very well, and that becomes a problem. Our only real treatment for this, our only real hope that we can offer these folks at this point is to try to increase preload and to aggressively give fluid in an attempt to keep preload up and increase preload. The obvious fix for it is to open their chest, find out what's bleeding, stop the bleeding, but even prior to that, relieve that pressure by opening the pericardial sac, we're not doing that in a pre-hospital way. So all we've got in our toolbox for pericardial tamponade is aggressive management of preload. So the 4 questions you ask yourself: what's the cause of the shock? What kind of shock are we dealing with? What can I take care of here? What's going to have to be taken care of somewhere else? Is there a cardiac output problem that I can deal with? Is it a volume problem that I can deal with? At all times, I'm going to have to maintain the airway and the ventilation our entire intent here is to maintain oxygenation. Maintain oxygenation at all costs. And so it's going to have to be an airway and breathing management thing, as well as working on whether it's a pump, a volume, or a container problem. Positioning works well. We talk about the 5 treatments of shock as: lay them down, keep them warm, go fast, control external bleeding, and give them lots of O2. And so lay them down. Place them supine. The Trendelenburg position, or head down, feet up, is no longer recommended. Supine is adequate. The problem with when you put somebody's head down and feet up is that you end up increasing pressure on their diaphragm and compromising their ventilation, which ends up being a bigger problem than not. So you get a lot of bang for your buck by laying them supine. That will get us most of what we need. So we're not doing Trendelenburg, and we're not raising the legs. Hemorrhage control has changed recently, fortunately. Some of those hard to implement phases of pressure points and pressure dressings and such have been eliminated. There was never any real research that they worked. We just did them. It seemed to be custom and legend, and then it became practice. And so direct pressure is the key, and you add to direct pressure with a tourniquet. So you continue direct pressure, and you aggressively move toward tourniquets. Tourniquets are not evil. They do make a difference, and early on especially, in where we have relatively short transport times, even in our system of a 20 or 30-minute pre-hospital time, that tourniquet can be life-saving, and the secondary effects or the side effects are not a big deal. Here's an example, a particularly gross example, of where a tourniquet was. I don't think there were many contraindications here. The limb was going to be lost anyway, but even where it's not this dramatic, in the case that we shared with the paramedic class on Facebook and the EMT class on a Facebook group of a couple of teens that were in an extrication, and the passenger had significant crush from essentially the waist down, was crushed, and not open and horribly mangled like this, but just crushed, closed injuries that were just crushed, and tourniquets were applied there, and a good outcome was achieved finally. As far as fluid resuscitation, we could spend an hour talking about this, but here's the bottom line. It used to be that we dumped fluid on patients as fast as we could, and that didn't help them. And so now we're trying to get a radial pulse back, which would equate with roughly a BP in the 80 to 90 range. You can't say for sure that the patient has a radial pulse, therefore their pressure is above 80. There's never been research on that. But in general, patients should have radial pulses. That's normal. So we use fluid resuscitation to get radial pulses back, and then we back off. Excessive fluid resuscitation causes harm and increases the acidosis problem. Even if it's warmed fluid, can increase the hypothermia problem. And realize that liter of IV fluid that you give, after an hour, there's only about 250 cc's of it left anyway in the vascular space. So it's only a temporizing measure, and the goal here is to get a liter or 2 of warmed saline into that patient, and the adult patient, to get their radial pulse back. And the same thing goes for this distributive or neurogenic shock. If the container's gotten too big, even if there hasn't been any fluid loss, we need to fill the container up. And so usually a liter or 2 will make a significant difference there. They don't even mention vasopressors here as an option. A lot of systems still use that as an option, but only after fluid resuscitation has failed to make the difference. On the cardiogenic side, deal with dysrhythmias as you usually would. Needle those tensions and get fluids for those tamponades. Keep them warm. We need to expose our patient to assess our patient, but once they've been exposed, assess and then cover back up. They want the patient compartment to be 85 degrees, so that's easier said than done, but the the comment that we make to our paramedic students is, if you're uncomfortable and you're taking off coats and jackets and layers, that's a good thing, because your patient doesn't have coats and jackets and layers to take off. So we want our folks to be sweating so that the patient is not cold. And in any case, reassess, 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 constantly reassess, and keep oxygenation happening. So left untreated, the vicious spiral occurs. You have multiple micro-organ problems, multiple organ dysfunctions, and the whole key, again, for us is to keep that cardiac output up so we can keep that tissue oxygenation going and use everything in our toolbox to do that. The hypothermia creates another vicious cycle that just adds to things. So you have hypothermia, you have lactic acidosis buildup, and these things, added to the third part of the lethal triad of coagulation problems, and it's no wonder that shock gets to where it is. Ongoing assessment, and you probably can't reassess these folks enough. So I'm going to conclude with this. Remember, shock is a problem with cellular hypoperfusion. We didn't get oxygen delivered to the cells couldn't produce energy, they couldn't do what they needed to do, and they began to self-destruct, and the vicious cycle occurs. And in our trauma patients, this is usually a bleeding problem, whether internal or external, so we need to assume that our patient has bleeding until we can rule it out. The problem is that we need red blood cells. We don't need molecules of saline or lactated ringers. And so our fluid resuscitation is aimed at keeping peripheral pulses, getting that radial pulse back until we can get them to where they can get some blood and go from there. So that's the second part of bleeding and shock.